Hi, I'm Mark Vitale. I'm a hand and wrist specialist, and I'm going to talk today about the use of orthobiologics in the hand and wrist. So, just as an outline of today's talks, we're going to define what are orthobiologics. We're going to talk about what conditions in the hand and wrist may respond to orthobiologic treatment, and we're going to review the current evidence and outcomes associated with use of orthobiologics for hand and wrist pathology. So, what are orthobiologics? So they are defined as derivatives of naturally occurring substances in the body that may accelerate healing of musculoskeletal injuries. And the data is really all over the place. There are lots of studies in the sports and shoulder and elbow literature. There's not a whole lot of evidence in the hand and wrist. And a lot of the evidence is somewhat flawed, so we're going to review that. And orthobiologics comprises a number of different agents. The most commonly used ones today are bone morphogenetic proteins, PRP or platelet-rich plasma, bone marrow aspirate concentrate, mesenchymal stem cells, and amniotic membrane. So we're going to talk about some studies that have investigated the use of these agents. So let's talk a little bit about each of these agents. So PRP is plasma with concentrated platelet content. So PRP is the portion of the blood that has factors that may mitigate inflammation and promote healing and tissue recovery. And there are a number of different types of PRP, which are classified by the presence or absence of white blood cells, activation methods, the number of platelets, and the method of preparation. Frequently, someone's blood will be drawn through an IV and centrifused in a machine, and the platelet-rich portion is utilized for therapies. So bone morphogenetic proteins, these are compounds that recruit osteoblasts, the cells that form bones, to the site of a lesion, and they're osteoconductive in nature. That means they help form bone. So there are many different types of BMPs. BMP 2 and 7 have been the most frequently studied and are FDA approved. They have been successfully genetically engineered to yield some promising results, and they have both anabolic and anti-inflammatory effects. So bone marrow aspirate concentrate, or BMAC, that originates from the extraction of bone marrow cells, frequently from the iliac crest of the hip. And there is evidence in vivo that there is generation of hematopoietic cells, fibroblastic reticular cells, and bone. Mesenchymal stem cells. So these are multipotent adult stem cells, meaning cells that can turn into any other types of cells, and they're responsible for regenerating and repairing skeletal tissue. They can be extracted from bone marrow or fat. They're capable of self-renewal, and they can turn into many different types of cells, including chondrocytes, adipocytes, and osteocytes. And lastly, amniotic membrane, which is one of the newer orthobiologics that's been studied. This is the avascular innermost layer of the fetal membranes, in which full-term placental tissue is treated with antibiotics during collection. And it's got 3 different layers that are important: the epithelium, the basement membrane, and the stroma. So the basement layer may promote cellular growth, the stromal layer may reduce inflammation, and overall amniotic membrane has been shown to have some anti-angiogenic and antimicrobial properties. So when you look at all these compounds, they're relatively new. Many of them are not yet FDA approved. For instance, PRP is not yet FDA approved, and neither are mesenchymal stem cells. And also, the cost is relatively high for many of these compounds, in the range of thousands of dollars per injection, and they're not approved by insurances. So, knowing this background, what is the evidence of orthobiologics for use in the hand and wrist? Well, we're going to review a few specific pathologies of the hand and wrist. So first, we're going to talk about a common tendinitis of the wrist, de Quervain's tenosynovitis. This is a tendinitis of the first dorsal compartment of the wrist, the tendons that extend your thumb metacarpal and radial abduct your wrist. And repetitive motion can cause an inflammation in this compartment, which causes swelling of the tendons, thickening of the compartment, friction, and eventually pain and swelling. The traditional treatment for this is rest, immobilization, anti-inflammatories, and frequently corticosteroid injections. Now, PRP has been studied for this condition. So what's the evidence? So there was one large study by Ramesh and colleagues in 2018 that looked at over 140 patients that had dequervain tenosynovitis, and they were treated with autologous PRP injection. Now, there was no comparison group. This was a case series, but the authors reported that more than 2/3 of patients had pain relief with the first PRP injection, and an additional 16% had pain relief with the second injection, administered 3 weeks apart. What's the problem with this study? These same patients may have improved on their own or with other methods because we don't have a control. So Peck and Eli in 2013 published another case series with no comparison group, and there was a group of patients that underwent an ultrasound-guided needle release of the first dorsal compartment followed by a PRP injection. And the authors reported that 6 months after this procedure, pain scores improved and there were no complications. Now again, what does this tell us? There's no comparison group, and the benefit may have been from the needle release and not from the PRP injection. So does PRP help dequervain tenosynovitis? I don't think we have any evidence, compelling evidence that it does. How about for thumb osteoarthritis? So I frequently have patients in the clinic that have pain at the base of the thumb from thumb arthritis asking, well, we've tried cortisone injections. Are there other options? Can we try stem cells? Can we try PRP? So what's the evidence? There's not a whole lot of evidence for orthobiologics for the thumb CMC joint. So one study recently in 2021 by Malhais and colleagues was a prospective randomized trial that had 33 patients with thumb CMC arthritis. So 16 of these patients underwent a PRP injection and 17 had a standard corticosteroid injection. Both groups improved at 3 months, but the PRP group had further improvement down the line and further improved outcomes in DASH scores compared to the corticosteroid group, which had worsening scores at 12 months. So here's some evidence that PRP is a reasonable option. However, this is a study with a small number of patients, and it has not been replicated. So how about another very common problem, carpal tunnel syndrome? So carpal tunnel syndrome is the most common peripheral neuropathy. It affects the hand, and it's when the median nerve in the wrist is compressed, which can cause some combination of numbness and tingling in the thumb, index, middle, and ring finger, pain, nocturnal symptoms, and eventually it can cause weakness of the thumb. So standard treatments for carpal tunnel often include corticosteroid injections, but there is mounting evidence that PRP injections may be a reasonable option. So for instance, a recent study by Senna and colleagues published in 2019 was a randomized control trial of 98 patients with mild to moderate symptoms that had either a corticosteroid injection or a PRP injection. Now, while there was no difference in 1 month between the groups, at 3 months there was a significant improvement in paresthesias, pain, and a carpal tunnel outcome score. So some moderate evidence that PRP may be a better option than a steroid injection for carpal tunnel syndrome. Another study by Malhais and colleagues in 2018 was a double-blinded randomized control trial that had 91 patients receiving PRP versus just a saline injection. And there was nearly a 77% success rate in the PRP group versus only 33% in the control group. Also, there was a greater improvement in outcome scores called a DASH score in the PRP group compared to the saline group. And there is more evidence. So another study by Wu and colleagues in 2017 looked at 60 patients with carpal tunnel in one wrist that received either PRP versus a wrist orthosis. At 6 months, there was significant improvement in pain scores, carpal tunnel questionnaire scores, and the size of the median nerve as measured by ultrasound in the PRP group compared to the control group. And lastly, another study by Shen and colleagues was a randomized control trial looking at PRP versus a control of a sugar injection in patients that had moderate carpal tunnel syndrome in a group of 52 patients. And they found also that the PRP group had significant reduction in carpal tunnel questionnaire score function subscale at 3 months, in their EMG scores at 6 months, and in the cross-sectional area of the median nerve as measured by ultrasound at 3 and 6 months. So is PRP a reasonable option for carpal tunnel syndrome? I think we can say there is mounting high-quality evidence that it is a reasonable option. So how about another problem in our field of hand and wrist surgery, scaphoid fracture nonunions. So the scaphoid bone is one of the small bones in the wrist that unfortunately has a poor blood supply, and when it is fractured, it has a high rate of nonunion. Nonunion occurs in 5 to 25% of scaphoid fractures, and the natural history results in arthritis, collapse, and eventually something called scaphoid non-unit advanced collapse, or a snack wrist, which can be a debilitating condition. So orthobiologics have been studied in the field of scaphoid non-union, specifically bone morphogenetic proteins. So one randomized controlled trial by Billick and colleagues in 2006 randomized 17 patients that had a proximal scaphoid pole non-union to receive either autologous iliac bone graft, autologous bone graft with BMP7, or allograft with BMP7. And the group that had BMP7 with autologous bone graft had enhanced healing, had some evidence of healing at 4 weeks versus healing at 9 weeks in the groups without BMP. CT scans also showed vascularized proximal poles in the patients with both BMP at 9 months. So some evidence that BMP7 can be a reasonable option. However, another case series in 2013 looked at 27 patients with a variety of hand and wrist non-unions of the phalanges, the carpal bones, the distal radius, and the distal ulna that were treated with ORIF with recombinant BMP2. So the results were inconclusive. 89% of patients had healing at a mean of 4 months after surgery, but this was no better than previously published rates without BMP2. So BMP2 doesn't seem to have a role. Also, another case series by Brannon et al. Looked at 6 patients with BMP2, and there were significant complications in the patients receiving BMP2, including extra bone formation, stiffness, and other complications. Only 1 out of the 6 patients did not have a complication attributed to BMP2. So is there a role for BMP in scaphoid non-unions? Maybe BMP7, probably not BMP2, and more data is needed. And lastly, one of the bigger challenges in our field of hand and wrist surgery, flexor tendon lacerations requiring repair. These are injuries which are very difficult to achieve a good result because of the stiffness that can develop and also the high rate of re-rupture. So various studies have looked at PRP to enhance flexor tendon repair in animal models. And let's briefly review that data. So an animal study by Sato and colleagues in 2012 looked at the effect of PRP with a fibrin matrix on healing of rabbit flexor tendons, and there was no difference in outcomes, including edema or adhesion formation at the tendon repair sites between the two groups. There was significantly increased healing strength at the repair site in the PRP group at 2 weeks versus control, but no difference in 3 and 6 weeks. Another similar rabbit model study looked at zone 2 flexor tendon repair sites with PRP versus no PRP, and there was no difference in tensile strength, tendon excursion, or range of motion between groups at any time point, and in fact there was decreased cell count indicative of less healing in the PRP group. Another study by Morizaki and colleagues in 2010 looked at a canine model, and this was a large study with 192 canine flexor digitorum profundus tendons repaired with a PRP preparation and bone marrow-derived stromal stem cells versus control. And they found that the maximum breaking strength of the healing tendons was significantly increased with the bone marrow stromal cell-seeded PRP patches compared to healing tendons without a patch. And lastly, Dr. Gelberman and colleagues out of the University of Washington in 2017 published a study looking at another canine model of 16 flexor tendon repair sites combined with administration of adipose-derived stem cells and recombinant BMP12. They found that the repair sites did not have adhesions or gap formations after this preparation of stem cells and BMP12, and there was possible modulation of post-repair inflammatory response and possible facilitation of healing, which was assessed by gene and protein expression. Again, we don't have a lot of great evidence for the use of PRP in flexor tendon repair, and it's all in animal models, but perhaps there's some promise. So what do we really know about the use of orthobiologics in the hand and wrist? Well, still in 2021, we don't know a whole lot. Most of these studies that have been published are case reports and case series that have no comparison groups. There are limited follow-up and low numbers in many of these studies, and we really need more high-quality randomized control trials. Also, much of the reported benefits are anecdotal and not experimentally proven. You'll hear someone say, my wrist got so much better after a PRP injection, but if you really look at the data, there's not a whole lot published. There are limited reports on donor site morbidity as well. And lastly, orthobiologics are not covered by most insurances, so that's an important point. So while there's an unclear role for use in the hand and wrist, there is some reasonable evidence for the use of PRP in carpal tunnel syndrome, as well as BMP for scaphoid nonunions. Thank you.